And now I would like to introduce our facilitator for tonight, Dr. Kylie Partlin. Kylie is a Shire GP and also a member of Sutherland GP Education Advisory Committee. Thank you, Kylie.
Thanks, Lydia. Welcome, everyone. Thanks for coming along. We hope we've got a really helpful talk for you tonight on common eye issues from the team at Sutherland Eye Surgeons. So we've got a few speakers tonight, so I might jump straight in and we'll keep it moving. Our first speaker is Associate Professor Matthew Siminovic. He's an ophthalmologist and vitreoretinal surgeon. He specialises in surgery and diseases of the retina and vitreous in children and adults. His clinical training was undertaken in Australia, North America and the UK. He is a surgeon at Sydney Eye Hospital and Sydney Children's Hospital Network, and he holds academic appointments at the University of Oxford and the University of Sydney. Associate Professor Siminovic is actively involved in research and in the training of retinal fellows, ophthalmology registrars and medical students. So we're very lucky to have him, and we thank you very much. Over to you, Matthew.
Thank you. Got my screen okay?
Yes, thank you.
Great. Thanks very much for the introduction. By way of overview, I'll cover the classification of age-related macular degeneration this evening. I'm going to talk about its epidemiology as well as its impact on patients. I'll briefly discuss its diagnosis before covering its management and current treatments. And finally, I'll cover some treatments for AMD which are on the horizon. I thought it'd be worthwhile recapping the importance of the macula. And as you all know, it's the very central portion of the retina, and it corresponds to the central portion of our visual field. And the macula has anatomical specializations which confer the features of our central vision. So these include a high density of the primary retinal neurons that we use under daylight conditions. These are the cones. They reach a peak density of around 120,000 cells per square millimeter in the central macula. This, as well as its connections to the second order and third neurons, gives us our high spatial resolution at the macula, that is good visual acuity. The macula also gives us our best color discrimination, as well as temporal resolution. That's the ability to detect things like flicker and movement. So I often tell my patients that the macula is to the eye as the thumb is to the hand. So whilst it only represents a very small portion of the retina, if it is knocked out, we lose much of our visual function, just as a lot of the function of the hand is lost with a loss of a thumb, even though it's only one of 5 digits. The term macular degeneration really encompasses a variety of phenotypes, as we'll see over the next few slides. And the pathogenesis of AMD appears to be multifactorial. It's not a single gene disorder, and a variety of genes have been implicated in its pathogenesis. And importantly, lifestyle factors appear to be crucial, including things such as diet and smoking status. The most widely accepted classification system of AMD is the Beckman system, and it divides age-related macular degeneration into early AMD, intermediate AMD, and late AMD. I'll show you some slides of these in a moment, but in early AMD, there are only medium-sized drusen. What are drusen? These are collections of cellular debris underneath the retina. And these look yellowish in appearance, and in early AMD, they're less than the width of the central retinal venule, which is about 125 microns. In intermediate AMD, there are drusen which are larger than 125 microns, or the width of the central retinal venule. Late AMD is divided into 2 forms. In the first form, there's growth of new blood vessels into the macula. This is often called wet AMD or neovascular AMD. Alternatively, late AMD is in the form of geographic atrophy, in which there's a loss of the outer retina structure and function. So I'm going to show you some slides of patients with AMD. So on the top left, we have a fundus photograph of somebody with normal age-related changes. And so this consists of, they're a bit hard to see, but some tiny yellow dots, a few of them, which are the drusen that I referred to earlier on. On the top right is a fundus photo of a patient with early AMD. There are some drusen there which are just over half the width of a retinal venule, but less than the width of the venule. On the bottom row, a couple of photos of eyes with intermediate AMD in which the drusen or the yellow spots are larger than 125 microns. These are photos of patients with late AMD. On the left, we have an example of a severe presentation of neovascular or wet AMD in which there is a large submacular hemorrhage next to the optic nerve head, the big sort of red or dark red patch. On the right, we have late atrophic AMD in which there's a large area of retinal atrophy or geographic atrophy. So in that area, it looks slightly orange and we can see some red lines there, and they represent the blood vessels in the underlying layer, the choroid. AMD is the commonest cause of irreversible sight loss in people over the age of 50. Data from an Australian study suggests that early AMD is present in close to 15% of people in this age group. Intermediate AMD affects just over 10%, and finally late AMD affects just under 1%, with an approximate 3-to-1 split between atrophic forms or geographic atrophy and neovascular or wet AMD. So in terms of the diagnosis and history and symptoms, in early and intermediate AMD, there may be no symptoms. However, patients may have difficulties in doing certain tasks very early on in the disease process. So for example, we know that adaptation to different light levels is impaired very early on, especially adapting to lower light levels after an exposure to bright light. So for example, if patients are driving and passing through a tunnel or are exposed to oncoming lights at nighttime. As the disease progresses, patients may notice other changes, for example, loss of fine detail vision. One early important symptom of neovascular or wet AMD is the development of metamorphopsia or distortion. And we often ask our patients at risk of developing wet AMD to self-monitor for this and to call us as soon as possible should they note it. In terms of examination, patients may have reduced visual acuity when they present, and they may have metamorphopsia on more formalized testing, such as the Amsler grid. On clinical examination, we may note some of the findings that I previously ran through. These days, an imaging modality called optical coherence tomography is an important means of assessing the macula, and we do this routinely on many patients with retinal disease. I've got some pictures of OCTs from a patient's right and left eyes with AMD at the top here. So this gives us a histopathological level of detail of the macula. So with this technique, we get a view of this patient's macula as though we're able to perform histopathology on them. And the level of resolution is pretty impressive. It's around 7 microns in terms of its axial resolution. And often we can make a definitive diagnosis of AMD with OCT alone. Traditionally, fundus fluorescein angiography was performed in patients with AMD. And I've got some pictures of fundus fluorescein angiography at the bottom there. This is a technique where we inject a dye, sodium fluorescein, into one of the antecubital veins, and we monitor its flow throughout the retina and the choroid using blue light photography. These days, we don't always have to perform this technique because we also have access to OCT angiography, which in some respects has replaced traditional fluorescein angiography. In terms of management of AMD, this depends upon its stage. Prior to the development of AMD, we can attempt to address modifiable risk factors. For example, we may recommend smoking cessation, which we do in general for all patients. Patients who have intermediate AMD or who have neovascular or wet AMD in one eye but not the other benefit from taking a so-called AREDS 2 formulation. This is a combination of vitamin C, vitamin E, copper, and zinc, with the addition of the flavonoids lutein and zeaxanthine. These are pigments that are normally concentrated at the macula. This lowers the risk of progression from intermediate AMD to wet AMD by around 26%. At present, there's no approved treatment for atrophic AMD, though it's likely that one treatment called pegcetaclan, which inhibits complement C3, will receive FDA approval as well as TGA approval in the not too distant future, as it's demonstrated efficacy in phase 3 clinical trials. Neovascular AMD is currently treated with intravitreal injections of anti-vascular endothelial growth factor agents or anti-VEGF agents. We inject these in rooms under local anesthesia, and their use is supported by multiple phase 3 clinical trials, as well as by high quality systematic reviews and meta-analyses. Around 40% of patients presenting with wet AMD will improve by 3 lines at 12 months following commencement of treatment with anti-VEGF agents, and more than 90% of patients preserve their vision. This slide summarizes the timeline for the development of the currently used anti-vascular endothelial drugs. There are 2 which are approved by the TGA for neovascular or wet AMD, which have been used for several years, and these are ranibizumab, which you can see second from the right, which is an antibody fragment which binds VEGF-A, and the newer drug is aflibercept on the right there, which binds VEGF-A and B, as well as placental growth factor. These charts demonstrate some of the real-life outcomes following commencement of anti-VEGF agents for patients with wet macular degeneration. As a general rule, you can see that after a year or so of treatment, patients typically do better. So that's demonstrated by the chart on the left, and this is from data primarily collected in Australia, although there's some drop-off in visual acuity over time. So the blue and the purple represent the number of letters that the patient can read on a letter chart. So you can see after 2 years, visual acuity tends to decline. Why is this? It can be due to undertreatment. It can be due to the development of atrophy or through the development of fibrosis. So the latter 2 cannot be actively treated at present. It's important to note that all of the current agents that we use are commenced with 3 loading doses, which we space 4 weeks apart. In the early days of therapy, there was a dilemma regarding how to minimize the treatment and the visit burden whilst maximizing treatment outcomes. And so the way that most retinal specialists will deal with this is through so-called treat and extend. So the way this works is that we do the 3 loading doses spaced 4 weeks apart, and we assess the response to therapy. If the macula has dried out, then we know that we've successfully addressed the problem, and we then lengthen the inter-injection period by 2 weeks typically, up to an interval of around 12 to 16 weeks, depending on the patient and the drug which is used. However, some patients cannot be extended. As a general rule, treatment is lifelong, insofar that the neovascularization and wet macular degeneration never truly regresses. And patients, if they are stopped in terms of therapy, often represent later with significant and irreversible sight loss. It's important to note that our patients also benefit from other services. It's very important that they have an up-to-date spectacle prescription every couple of years, and they generally will see their optometrist for this. Patient education is important. For example, educating patients about monitoring for signs of wet macular degeneration if they have intermediate macular degeneration. And the Macular Disease Foundation is excellent in this regard. And they also act in patient advocacy and they support important research. Some patients benefit from low vision assessments. And this is where both Guide Dogs and Vision Australia come in. I touched before on the fact that treatment for wet macular degeneration is lifelong, and a significant number of patients require monthly injections still. And this places a huge burden on our patients as well as their carers, and it highlights one of the key problems with current treatments, and that is the durability of treatment. And this is being currently addressed through a variety of approaches. For example, new anti-VEGF medications are being developed, including one called faricimab, which is likely to achieve TGA approval in the not too distant future. Around 80% of patients on this medication can be maintained with intravitreal injections at every 12 weeks or longer. Other approaches are being developed as well. For example, a port delivery system has been approved by the FDA recently. I've got a surgical video of a patient undergoing this procedure at Sydney Eye Hospital because we're involved in a clinical trial in which this port delivery system is placed. We place this surgically into the sclera. It's more or less a depot device or a little pot which continuously releases ranibizumab into the vitreous cavity. Other approaches are also being developed, including gene therapy. And I mentioned earlier on that in the not too distant future, there may be active treatment for patients with atrophic macular degeneration. So in summary, AMD is the commonest cause of irreversible sight loss in those over 50 years in Australia. And intermediate and late AMD affects more than 10% of this age group. Metamorphopsia or distortion is an important symptom of progression to wet macular degeneration, and patients with this symptom require prompt referral and assessment. AREDS 2 formulations consist of a mixture of antioxidants and the flavonoids lutein and zeaxanthine, which are normally concentrated in the macula, and these are of benefit for patients with intermediate AMD or who have wet AMD in one eye. Treatments for neovascular or wet macular degeneration are available. However, treatment must be maintained in order to maintain vision. And as I've discussed, new treatments are on the horizon which address some unmet needs, including durability of treatment, as well as prevention of sight loss from atrophic macular degeneration. Thank you.
Thanks very much, Matthew. Well done on sticking to time. I might just jump in with one or two quick questions since we've got a couple of minutes for questions, if that's okay.
Yes, sure.
I mean, how are most of these patients with early macular degeneration being picked up? I mean, what can we as GPs be doing to try and pick these patients up earlier, I guess?
Yeah, so that they don't need to. So if they've got early macular degeneration, they don't necessarily need to see us. But you know, patients should be seen, you know, after they're 50, at least every couple of years by their optometrist, and they're generally well followed up by their optometrists. If they have some macular changes, their optometrist might see them every year, and they'll give them an Amsler grid, which looks kind of like a you know, crossword puzzle that hasn't been filled in. But there's some evidence that patients are hopeless at using those in real life. A study was done in London where they compared, you know, instructing patients to use an Amsler grid to asking them to look at things in their everyday life. And they're actually a lot better at picking up distortion or metamorphopsia when looking at things in their everyday environment. That's more sensitive than using an Amsler grid. Yet we always give, I've stopped doing it, but there's like a knee-jerk reaction to give people Amsler grids. So they're really, really sensitive when you talk a patient through it. At home, people just don't know how to use it properly.
So, I mean, I guess the optometrists are probably talking to them about that and keeping an eye on things, and then referring on to you once.
Yes. So essentially, they will refer them on to us when there's sort of any untoward changes. I mean, that study that I mentioned earlier on also addressed the fact that quite often patients, even when they're instructed, won't know where to go or will go to the wrong place. So, for example, in that study, they instructed them to call the study team when they noticed metamorphopsia or distortion of their vision, and most of them either went to their GP or to emergency.
Yeah. So, I mean, that's a common lesson, isn't it? Patients don't always.
We come across that all of the time. Yeah.
Yeah. I guess another question might be then, I mean, you mentioned obviously quitting smoking is very important. What are some other, I guess, preventive things that people can do if they either have a family history or they're, you know, concerned about macular degeneration?
Yeah, so we've mentioned sort of the importance of sort of regular checkups if there's a family history. Look, we think diet is important. You know, the things that are good for their body in general, I tell them are good for their eyes. So in particular, you know, the compounds that are found in sort of AREDS2 formulations are found in sort of fruit and vegetables, highly colored fruits and vegetables. Green leafy vegetables have a lot of those pigments that are concentrated in the macula, lutein and zeaxanthin. You know, we think that lutein and zeaxanthin are good for macular health, but nobody really actually knows why they're concentrated in the macula. There are a few kind of theories. One is that they absorb blue light. One is that they scavenge free radicals and that they kind of prevent oxidative damage. And there's another theory that they're not there for either of those two reasons. They're there to improve our color discrimination. So the jury's still out, but yet they seem to be a benefit from the studies that have been performed. So there was a recent publication of a 10-year follow-up with people on these formulations, AREDS2, and the addition of lutein and zeaxanthin appears to be a benefit. It's better than vitamin A, which was in the AREDS or the original AREDS formulation.
Right, lovely. Okay, well, I think we're probably out of time for you. So thank you very much for your time, Matthew.
Thanks a lot.
And I'll move on to our next speaker. So our next speaker is Dr. Michael Davies, who's an ophthalmologist and oculoplastic surgeon. Michael Davies is a comprehensive ophthalmologist with subspecialty training in the management of eyelid, eye socket, and tear duct disorders in adults and children. His oculoplastic fellowships were completed in Australia and Canada. Dr. Davies is a visiting medical officer at Concord Hospital, where he supervises registrars training in oculoplastics, and he has been appointed as a clinical senior lecturer in ophthalmology at the University of Sydney. So I'll hand over to you. Thanks, Michael.
Thanks, Kylie, and thanks for the opportunity to talk to you today. I'll just share my screen there. Can you see that there now?
No, yes, and full screen. Excellent, thank you.
Thanks very much. I'm going to talk today a little bit about periocular lesions, which is a reasonably common presentation that you would see in general practice. So we'll launch right into it. Benign periocular lesions, so we'll start there. Now, this is by no means exhaustive. There are a number of other things that can pop up around the periocular region, but this is just an overview of some of the more common ones that you would come across. And we'll go through all of them individually there. So chalazions, exceedingly common presentations to us and to you guys as well. So these are lipogranulomatous reactions to blocked meibomian glands, meibomian ducts, I should say. They're not actually an infection, but they can develop overlying cellulitis. So occasionally they do need some treatment with antibiotics, but in general, it's not an infectious process. The patient often will have an underlying cause for it, and most commonly that is blepharitis or rosacea, which are predisposing them to these lesions. Management, so typically we would start with conservative type treatments, so heat and massage, will get rid of the vast majority of these lesions. So I normally just get them to get a hot face cloth or one of those wheat packs, leave it on the area for 2 or 3 minutes, and then massage towards the center. So the top lid you would be massaging downwards, the lower lid you'd be massaging upwards. Try and do that 2 or 3 times a day, ideally. You want to treat any underlying predisposing factors. So as mentioned with the blepharitis and the rosacea, if they're getting recurrent lesions, you want to treat that. The blepharitis, we talk about lid hygiene. So essentially that's just cleaning along the edge of the eyelid margin to remove any debris or any thickened oil secretions that tend to build up there and lead to the blockage of the duct opening. Flaxseed oil, which is just an oral preparation, has been shown to soften up some of the constituents to make it less likely to clog up the opening. And then in refractory blepharitis or significant rosacea, oral doxycycline is often very effective as well. Failing that, failing the conservative measures, if the lesions persist, we generally perform incision and curettage as an in-rooms procedure. So you can see here, we've made an incision from the inside surface of the eyelid. That's a Calazian clamp, which is holding the eyelid still and allows us to evert the lid, gives us control if the patient feels like they need to blink. But all that lipogranulomatous material is coming out and usually settles down very quickly after that. Hordeolums, sort of similar, but in this case, it's a bacterial infection of one of the lash follicles or one of the sebaceous glands, typically a Staphylococcus species involved. Treatment in this case is, if there's any suggestion of any overlying cellulitis, then you would treat with oral antibiotics. And if there's a suggestion of any abscess present, then again, a minor procedure in the office just to drain that away. Seborrheic keratosis, so this is the most common eyelid lesion, benign eyelid lesion that we would see, typically in older patients, often multiple in presentation, and they have this appearance of flat brown pigmented lesions, sometimes described as a squash sultana. And the mainstay of treatment for these is surgical excision, as it is for most of these benign lesions. Papillomas, so these arise from the squamous epithelium, often related to HPV, and they have finger-like extensions and irregular surfaces. As you can see on the left there, they can arise from the conjunctival epithelium, or on the right there, that's arising from the skin epithelium, and they're both papillomas. Hydrocystomas, so these are translucent or semi-translucent lesions that arise from sweat gland structures, and they can either be clear fluid or clear fluid with some cellular debris in addition. Classically see them around the medial canthus. So removal of these involves excising the cyst completely, including the cyst lining. You just have to be very careful in the medial canthus that there's no damage to any underlying tear drainage structures. So often put a probe into the canaliculus so that there's no damage there, and just remove these in the rooms as a rule. Nevi, very common around the eye. As you know, benign growths of melanocytes, and they can be melanotic or amelanotic. On the right there, you can see just a marginal nevus there with no pigment whatsoever, but this is quite a common presentation. And in fact, I would say in my practice, I see many more amelanotic nevi than the ones with pigmentation. Pyogenic granulomas, so these are fast-growing, soft, pink fleshy masses arising on the conjunctival surface of the eyelid. They typically will occur in relation to a chronic chalazion that has self-discharged and is gradually sort of oozing material. You get this reaction, granulomatous reaction. They can arise also in the setting of previous surgical incisions or trauma as well. These don't tend to go away by themselves, so if you see them, we usually will excise these again just under local anaesthetic. Xanthelasma, so these are yellow deposits within the dermis around the eyes, composed of lipid-laden macrophages, and they are more common in patients with elevated serum lipids, but often you see this in patients who don't have elevated lipids. It's probably worth checking for that if you see it. Treatment, there's various things that have been described in terms of treatment. The laser ablation and cryotherapy tend to sort of partially treat it. The definitive treatment really is surgical excision, but it just depends on how widespread it is. If it's large enough, sometimes you require skin grafts to enable the lids to close properly and things afterwards. Moving on to malignant periocular lesions. So really the big three here, no surprises, basal cell carcinoma, squamous cell carcinoma, but the one that people sometimes forget about or aren't as familiar with is sebaceous carcinoma. It's an important one to remember, and we'll go through all of these in a minute. Really the others, and they're myriad, any type of skin cancer or any type of sort of cancer really can form on the eyelid margin, but you're talking about less than 1%. Even things like melanoma are quite rare. But all the usual things that can affect elsewhere can affect the skin around the eye. So BCC, so I often give this talk to optometrists, so you'll be well across a lot of this stuff, but just to sort of recap, most common periocular malignancy, often firm non-tender lesions. Classically, they have raised, rolled, pearly edges, particularly in the nodular subtype. They can have abnormal blood vessels on the surface, ulceration, and loss of normal lid architecture, so namely lash follicles, meibomian glands, hair follicles, etc. Depending on the subtype, that sort of dictates the risk of the lesion. So nodular and superficial tend to be classified as lower risk, and sclerosing, infiltrative, and micronodular higher risk. And they spread locally, but they don't metastasize. Just a slide here illustrating the kind of varied presentations of basal cell carcinoma. So up the top, those two slides show nodular forms of BCC with the firm raised edges, the central ulceration. But the lower picture as well is also a BCC. So this is an infiltrative subtype. And really the keys here are the lash loss, the ectropion that's been induced by the cicatrization of the skin. And you can appreciate it's quite difficult sometimes to see where the edges of the more infiltrative forms actually finish. Squamous cell carcinoma, so this is about 5 to 10% of periocular malignancies. Classically, they'll present with erythema and hyperkeratosis, often have the same sorts of features as the BCCs can have, so ulceration, loss of normal lid architecture. The biggest prognosticator is the grade of the tumour, which is determined histologically. SCCs are much more prone to perineural spread and metastasis. So neuropathic pain is classically associated with SCC. And because they tend to spread along those pathways, there's a higher mortality rate than with BCC. And again, just to show you the potential differences in clinical presentation. So both SCCs on the left there, a very nodular looking lesion with a keratin horn on the surface, whereas on the right there, really it's just an erythematous sort of placoid area with some ulceration and some crusting and some lash loss. And sebaceous carcinoma, so it's only a small number of eyelid malignancies in many of the studies that have been reported, but in truth, it's actually much higher in the Asian population. And in many studies in Asia, it's actually more common than SCC in the periocular region. So it's an important one to remember. These are cancers that arise from the meibomian glands, and therefore there's an upper lid predilection because there are more glands on the upper lid. They can sometimes have a very obvious yellow coloration, but not always. There are different variants, and the two main ones are nodular and diffuse. And sebaceous carcinoma is a great mimic. So a nodular sebaceous carcinoma can resemble a chronic chalazion. So you always need to think about that if there's a patient getting chalazion that keeps coming back, even though it's been drained more than once. Whereas the diffuse subtype can resemble a chronic blepharitis or a chronic conjunctivitis, the clue being that it's unilateral as opposed to bilateral. Because of the late diagnosis, it has a much higher overall mortality, so around 10%. And the classic histological feature is pagetoid spread, so deep to superficial spread either via the conjunctiva or the skin epithelium. So in these carcinomas, you need to do mapping biopsies of from all over the periocular skin area and all within the fornices, so within on the conjunctival surface, on the inside of the eyelid as well as the surface of the globe. So again, this on the left was a lady who had a large nodular sebaceous carcinoma, which was very obvious, whereas on the right, it took a little bit more time to sort of work out exactly what was going on. The only clues really were just the chronic blepharoconjunctivitis and the lash loss, but both of these ended up being sebaceous carcinoma. It's really important to mention Muir-Torre syndrome when you're talking about sebaceous carcinoma. So this is an autosomal dominant cancer syndrome, which is believed to be a variant of Lynch syndrome. And these patients have a predilection to developing sebaceous tumours, either adenomas or carcinomas, and are associated with other visceral malignancies, classically colon cancer. It's histologically, the pathologist will do immunohistochemistry for DNA mismatch repair proteins because an absence of these is quite highly correlated with this Muir-Torre syndrome. But basically, any patient that I see where they have a sebaceous tumour on histopathology, I will liaise with the GP and recommend that they see a geneticist because they can test for germline mutations. You know, sometimes the sebaceous tumour might predate the visceral malignancy by 20 years. So you want to know about that ahead of time. This is probably the take-home slide from the talk here. So these are the red flags to look for when you're looking at periocular lesions. So matarosis, lash loss, any change in lid malposition, so entropion or ectropion, ulceration within part of the lesion, telangiectasia, which you classically see with BCCs, but can be seen in other types. Again, as we mentioned with sebaceous, that chronic unilateral conjunctivitis or a recurrent chalazion, always think, you know, could this be sebaceous? Neuropathic pain in association with an invasive squamous cell carcinoma. Yeah, by the time you get to orbital invasion, it's usually quite obvious that there's a significant process going on, but orbital signs, so proptosis, motility disturbances, tethering of the globe, and obviously lymphadenopathy if it's spread from there. Surgical management. So the mainstay of treatment for smaller lesions is excisional biopsy. If it's a large lesion or you're not sure where the margins start and finish, then an incisional biopsy is often very useful because you don't want to sort of commit the patient to major surgery if you're not sure what you're dealing with. As mentioned with the sebaceous carcinoma, mapping biopsies are essential to make sure you're not missing any extra disease there. The concept of margin control is really important. So by that, we're talking about either intraoperative frozen section or Mohs surgery. And that's particularly useful if there's a large ill-defined lesion, if there's canthal involvement, particularly medial canthus, because that's a place where it can actually spread posteriorly into the orbit very, very easily, or involvement of the lacrimal outflow apparatus, then you want to conserve as much tissue as possible. So margin control is essential. And if it's recurrent disease, it's often very useful as well. For more severe disease, orbital invasion, then exenteration where we remove the globe and the contents from within the socket altogether is occasionally required. You all know what Mohs surgery is. I won't dwell on this too much, but suffice to say that it's very well suited to the periocular region because you're typically really trying to conserve as much tissue as you can because the reconstructions can be quite tricky if you run out of tissue. So I often work closely with dermatologists who will do the Mohs excision and we will do the reconstruction. So we've got quite a close relationship with the dermatologists in that regard. Just a few slides of potential ways to repair some of these lesions. I mean, again, there's lots of different flaps and grafts and things like that you can use, but just a couple of pictures to show us what some of the things we do. So this was a rhomboid flap in a young patient. You can use bilobed flaps. They're good for lesions below the medial canthal tendon there in the medial canthus. You can use a glabella flap from the sort of brow region, rotate that down if it's above the medial canthal tendon. As I said, Mohs surgery we often use for poorly defined lesions, and you're almost hesitate to sort of open the photograph that the dermatologist sends back to you, because often there's a really large defect there and you sort of have to start playing mental Tetris to work out how you're going to put it together. But, there's a few trick shots that we've got. And this was a lady who had a very, advanced infiltrative BCC, but with a couple of different flap repairs. She actually did very well. There are other treatment options. So radiotherapy is actually a very good option, especially for patients who are unfit for surgery. The downside being that you don't have a surgical margin, and therefore it's very difficult to know if the lesion is completely gone. Cryotherapy, often for much more superficial disease, it has a role, but any larger lesions, it's a little bit difficult to completely remove those. Different immunotherapies can be quite useful, again, for the more superficial disease, Bowen's disease, things like that. You just need to be really careful around the eye, because typically all these therapies are quite toxic to the ocular surface. So, you just got to be really careful about explaining to them that they need to use it very sparingly and don't get it anywhere near the eye. There are some newer generation medications that have popped up in the last few years. So one in particular that I just wanted to touch on is vismodegib for advanced basal cell carcinoma. So this is a hedgehog pathway inhibitor, and it was designed. It's really been used in two ways. So it's therapy for BCC that's inoperable, but it's also used as neoadjuvant therapy for advanced BCC, and that, for example, would maybe get you from a situation where a patient was going to lose the globe altogether to a globe-sparing procedure, which obviously makes a big difference to the patient. It does have some downsides, so it has lots of side effects. And when you stop using the medication, it wears off and the lesion returns. But it definitely has a role to play in advanced BCCs, and it's actually now available in Australia. It's PBS listed. You need authority, of course, but it's another option to have in the arsenal. Now, this is just by way of example. So this is not one of my patients, but this was from one of the seminal papers from MD Anderson in Texas. And this was an unfortunate gentleman who I think he was homeless and just let this BCC get out of control. And it's almost difficult to see where the lesion was now. It's made such a difference. So it's something for advanced cases that's a newer development that I thought was worth mentioning. And just a couple of references there. Thanks very much.
Lovely. Thanks very much, Michael. We are probably right on time for you, but I might just quickly jump in and just ask, with chalazion, you mentioned like doxycycline, if we've got a persistent chalazion.
Yep.
What dose and length of treatment would you suggest? And I guess at the end of that, if it's not improving, we send to you?
Yeah, so just to clarify, I think it's really more for preventing new lesions from arising. So if they're getting chronic or multiple chalazion coming up, it's a really good circuit breaker. It can really knock the blepharitis on the head and really improve that sort of surface of the lid margin and prevent new ones from popping up. But if it's a chronic chalazion that's persisting, then I would go to surgical management. But with the doxycycline, what I typically suggest is they only have to be on a very low dose. So either 100, depending on the size, either 100 milligrams per day or even 50 milligrams per day. But they need to typically use it for about 3 months. And you have to warn them as well, as you know, just the increased chance of photosensitivity. So be careful if you're out in the sun, as well as potentially exacerbating if they've got some gastroesophageal reflux. You don't take it and then lie flat. You basically take it when you're up and about, and with food is better. So there's a couple of things to warn them about. But it's sometimes really a big game changer for patients that keep getting recurrent chalazions coming along. And as you know, with patients with underlying rosacea and things, it can make a big difference to their skin overall.
So it sounds like it's probably something that you might be instigating anyway, because I imagine if they've had the recurrent chalazion, we've probably referred them on to you anyway.
Yeah, I mean, look, I think it's reasonable for the general practitioner if they've got, chronic blepharitis or they've had one or two lesions. I mean, it's something that you could easily manage. So I think that's a reasonable option. But obviously, we're always happy to be involved.
Yeah, lovely. Okay, well, in the interest of time, we might keep moving. So thank you, Michael. And we'll move on to our next speaker, who is Dr. Matthew Wells, who's an ophthalmologist and glaucoma specialist. Dr. Wells has expertise in the diagnosis and management of glaucoma. He studied medicine at the University of Notre Dame and completed a subspecialty fellowship in glaucoma at Westmead Hospital. Dr. Wells is trained in the surgical management of glaucoma using trabeculotomy, aqueous shunts, as well as minimally invasive glaucoma surgery. Dr. Wells is a visiting consultant ophthalmologist at Sydney Eye Hospital. He also teaches at the Sydney University Ophthalmic Master's course. So thank you very much, Matthew.
Good evening, everyone. Can you all hear me?
Yes, thank you.
So I thought I'd spend some time speaking about allergic eye disease this evening. And I thought we'd sort of look at our kind of bookend of our patient cohort, spending some time looking at allergic conjunctivitis in our younger patients, and then also the topical glaucoma drop intolerance for our more elderly patients. So by way of overview, I thought I'd show my typical treatment kind of step ladder for allergic conjunctivitis, and then also help you to start recognizing some of the common glaucoma side effects from the drops that people take. And then we'll work on some strategies how to minimize these side effects and then think about what to do when these strategies don't work. So look, we've all seen allergic conjunctivitis. The itchy burny can be one of the most frustrating symptoms our patients have. And typically we've got the seasonal allergic conjunctivitis and the perennial, with really the only difference being that the seasonal gets slightly better in winter. It's typically not hard to diagnose this condition. Our patients, they normally have a raft of other allergic issues going on. They'll have red, watery, itchy eyes, and often associated with sneezing and nasal discharge. These patients come in, their eyes are bright red. They'll have a mild papillary reaction. I'll talk a little bit more about that. And sometimes you can even get swelling under the conjunctiva. It's called chemosis, and lid edema in more advanced cases. So I guess this is one of the clinical pearls for tonight. Ophthalmologists like to make a big deal of distinguishing between papillae and follicles, and this is obviously a picture of two very inflamed upper tarsal conjunctivae. The picture on the left of the screen is of papillae, and the hallmark feature of the papillae is that they have these central blood vessels emanating from each of these little areas, and that's typically associated with allergic disease. And that's in contrast to over here on the right-hand side. This is more of a follicular reaction, and the follicles are usually described as sort of translucent, sort of semi-cooked rice appearance, and these represent a proliferation of lymphoid tissue, and we typically see these more in infective type processes. So that's actually quite helpful when you're trying to diagnose, is this just an exacerbation of this person's allergic disease, or am I worried that I'm missing like an infective conjunctivitis that needs some other treatment or investigation? So this is my typical treatment step ladder. And for very mild disease, you can often get away with just preservative-free lubricants for patients. They refresh the eye, they get rid of that sort of itchy, burny kind of feeling. And sometimes that's all that's required. I try and avoid the preserved bottles and go for the more preservative-free, they're the little ampules. They're quite helpful because they can have them in their pockets, they can have them in the office, in their handbag, and they tend to use them, more frequently. I try and steer clear of the vasoconstrictor type products, so things like Visine, they really just sort of mask the symptoms. They don't really treat the underlying cause of the issue. And they're also at risk of sort of reflex or rebound redness when they stop the drops. So for the people who are really struggling, moderate disease, the antihistamine mast cell stabilizer product drugs work really well. So Zatadin and Patanol are the two most commonly drops that I'll use for my patient. Both of them come in preservative-free options. Use them twice a day. They'll often give quite rapid relief to symptoms. And then also, if they can use them in an extended sort of period to, protect against recurrences. For severe disease, I'll often use, and you'll often sort of need a bit of a steroid burst just to reset everything. And when you're doing this, I guess always we just need to be kind of at the back of our mind, excluding any infective type process. So maybe you're missing a sneaky keratitis or something. So just putting some fluorescein that you'll have in your rooms in with the blue light. And if you can sort of reassure yourself that the cornea is looking pretty good, then you're usually safe to start some steroid therapy. So that's sort of short and sharp review of allergic conjunctivitis that sort of typically affects our younger type patients. And now I'll spend some time looking at sort of the other end of the spectrum, so our more elderly patients. And the other main reason that they come in with sort of red, miserable looking eyes is due to their glaucoma drop allergy. So as we all know, glaucoma is a chronic progressive disease characterized by damage to the optic nerve, and that causes visual field loss that's irreversible. The major risk factor is raised pressure, and we're finding more and more about the genetic components of glaucoma. There's still a lot that we don't understand or know about glaucoma. Some people with high pressure still don't have any nerve damage. And also some people with normal intraocular pressure still manage to have, quite advanced vision loss because of the nerve damage that occurs in glaucoma. It's very, very common. So by the age of 80, 1 in 8 people will have glaucoma. And like many of our chronic diseases, such as diabetes, it's largely underdiagnosed. So 50% of people with glaucoma don't know they have it. So the first line of treatment in glaucoma is usual topical monotherapy. We've got 4 drop classes that typically work quite well. And the reason people become intolerant of their medication usually split into systemic or local side effects. We're usually pretty good at preventing, systemic issues, and we'll take a careful history about any, respiratory or cardiac issues before prescribing a beta blocker. So that's unusual. But local problems due to drop toxicity are very, very common. So these are the things that, again, you'll probably be very, very familiar with. All our glaucoma patients, a lot of them have blepharitis. They get these abnormal lashes. So the men really dislike these very long lashes, and the women tend to not mind it so much. They get this periocular discoloration that, again, affects some people more than others, and can be very frustrating. The corneal surface tends to become quite dry and irritated with these drops. And we also see a lot of conjunctival inflammation. People can also even get like a little periocular dermatitis under their eyes. And something that's been recognized more recently is this orbital fat atrophy with long-term prostaglandin therapy. And I'll show you a few pictures of all of these now. The main reasons for these drop intolerance is twofold. The first one is that the preservatives used in all these drops do tend to elicit a reaction after, decades of use. These ones I've listed here, they're all the same ones that are listed in the lubricant drop bottles and lots of other ocular medications. And, again, in small doses, they're not so bad, but when they're being used over years to months to decades, they can really start to cause some problems. A lot of the glaucoma agents themselves are quite irritating. So there's sort of 2 families that are particularly bad are the prostaglandin analogs. So that's your Zalatan, your Lumigan. they have a pro-inflammatory effect, and even to the point where we can see inflammation in other parts of the eye, such as the macular edema, and alpha agonists. So that's iopidine and alpha-GAN. Yeah, they're also notorious for causing red, stingy eyes. So just some pictures to bring these words to life. This is a lady with quite advanced bilateral fat atrophy, orbital fat atrophy. You can see her lashes are quite irregular, and the conjunctiva is a little inflamed. This particular lady, you can see very obviously this periocular, skin discoloration is quite frustrating. Her lashes are very irregular, and she's got blepharitis and have lots of crusts when waking in the morning, and her ocular surface actually doesn't look too bad. And this is admittedly a very elderly gentleman, but he's got such incredible blepharitis that he's hardly got any eye, and very red, inflamed ocular surface. So again, probably one of the more important slides in the talk is what can we do about reducing glaucoma drop toxicity. So again, we've talked about the fact that many of our patients will be taking these drops. And so the key things to do are go preservative free if you can. So thankfully, a lot of these preparations like Ganfort and Lumigan, Suflotan, they all come in preservative free options. So if you're noticing that the patient's looking red, scratchy or uncomfortable, that's something that you can suggest to the specialist to consider. The combination drops are becoming more common, and these are a great way of just decreasing the volume of drops that are going into people's eyes. So for instance, Xalacom combines Xalatan and Timolol. So you've gone to Xalacom just Nocday, 1 at night, as opposed to Xalatan nightly and Timolol, which is twice a day. So you've gone from 1 drop down from 3, which again is very helpful. More in keeping with the sort of reducing systemic side effects is punctal occlusion. So very firm pressure for 2 minutes after any eye drops that go in has been shown to reduce risk of systemic absorption. Even something as simple as a little bit of Vaseline under each eye, if someone's getting a lot of periocular inflammation, can be helpful. And again, if they're getting very sort of dry, scratchy eyes, topical lubricants and blepharitis treatment can also be helpful as well. So look, I think the main thing is I always stress to my patients to, come back if these drops aren't agreeing with you. We all know that the adherence is much worse in people who are not comfortable on their treatment. And so it's in everyone's interest that, people can take their drops without developing these symptoms. And I think as GPs, you're in a very privileged position that people are far more honest with you than their specialists who they see, once every 6 months or once every year for even some of these patients. And so, look, I think you have a really great position to be recognising these problems and advocating for your patients and bringing them up with their treating specialists. So what happens if these solutions don't work? Well, thankfully, we do have some other options for the people who have developed drop allergy. I'll go through these now. So one technology that is becoming more and more frequently used is SLT, and that stands for selective laser trabeculoplasty. I explain that to my patient as equivalent to sort of usually about 1 bottle of drops. So it's a very gentle laser, so a neodymium YAG laser that is applied to the trabecular meshwork. So that's the area of the eye where the cornea meets the sort of sclera and the iris all together, the angle. And the trabecular meshwork cells preferentially take up that laser energy, and the inflammation and remodeling that occurs once that's happened tends to improve the function of the trabecular meshwork, and the pressure is lowered. There's a very kind of pivotal study done in the UK that showed that SLT was, had a very similar safety and efficacy profile to first-line as a first-line glaucoma treatment to like your prostaglandin analog, and it's very commonly used over there. And I'm using it more and more in practice for patients at the start of their glaucoma journey, or patients sort of when they've been on all the other drops and we're looking for something else to drop the pressure even further. But yeah, something that's becoming more and more popular. So eye stents fall into the category of minimally invasive glaucoma surgery. So you've probably heard about a trabeculectomy or a tube insertion, and that's reserved for the very end stage glaucoma kind of patients. But for people, again, on 1 or 2 bottles, this can be often enough to get them off their glaucoma medication. So it's exceptionally handy for people who are really struggling with redness and irritation. Typically, we do this at the same time as we're doing cataract surgery, and it can be, really gratifying to get people sort of improve their vision because of their cataract, often get rid of their distance glasses and get rid of their glaucoma drops, and they're exceptionally happy after the surgery. So it's basically a little rivet that is implanted into the trabecular meshwork, and this allows the aqueous to pass through this little hole here directly into Schlemm's canal, lowering the intraocular pressure. As I mentioned, we still have our other glaucoma filtration surgeries available for people who need very low pressure or who cannot take any topical drops, which still occurs, but these have a much higher side effect profile than the other interventions that I've mentioned previously. This is sort of on the horizon as far as a glaucoma medication implant. This is very clever medicine because it's delivering the correct amount of medication to the actual most effective site, and just these little degradable pellets are injected into the AC using a little trocar, and that little pellet there will just settle to the bottom of the AC down here, where it dissolves over 6 months. Still having a few issues with that technology in that it needs to be repeated every 6 months, so they're looking for longer lasting medication, and the biodegradability of it, as far as being able to use it on multiple occasions, they're still working on that. So I guess the take-home messages, that glaucoma is very common. We've got great treatments, but there's often many side effects that come with them. As I mentioned, you guys are in a really privileged position. You have a really great relationship with many of your patients. They're far more likely to be forthcoming with you than their sort of specialists that they see less frequently. Ask them how they're going. If they've got red, miserable looking eyes, ask that question. And then if they do sort of say that they're struggling a little bit with their drops, then please let us know, because there are all of the alternatives available. I might leave it there. Thank you for having me, and I look forward to hearing some questions.
Please, thank you very much, Matthew. Given that 50% of glaucoma is undiagnosed, what recommendations would you have in terms of us trying to improve that?
Yeah, as Matt mentioned, the optometrists play a huge role here. Intraocular pressure measurements, very easy. Now we've got many non-contact ways of measurement that you don't even need to touch the eye with a little puff of air that they've got, or rebound tonometers. And most people over 40 years of age should be having an eye check every 1 to 2 years. The terribly frustrating thing as a glaucoma doctor is that glaucoma is usually very well treated, and if detected early, many people may not ever lose any peripheral vision. But it's still heartbreaking when people roll in with really advanced field loss that they either had never seen an optometrist to get a pressure check. And I know that if someone ever does come in noticing that they do have some change in their peripheral vision, that really is a sign of quite advanced disease. So yeah, and as the other thing I mentioned in the talk, family history is hugely important here. So anyone whose parents or grandparents, aunties and uncles have glaucoma really should get checked as well.
And from the age of 40, you say?
Yeah, well, look, it's kind of handy because typically people start to become presbyopic around 40. They need their reading glasses, and that usually is what precipitates them to see the optometrist. And that's pretty much standard of care now. When they go and see the optometrist, they'll get a pressure check, and often even a fundus photo, which is also really helpful in picking up any anomalous looking nerves.
Yeah, okay, lovely. Well, we're actually probably just sticking to time, so we might leave it there for you. So thank you very much for your time, Matthew, and for your talk. And we'll move on to our final speaker for tonight, Dr. Michael Rossiter Thornton, who's an ophthalmologist and anterior segment surgeon. Dr. Michael Rossiter Thornton is an experienced anterior segment and cataract surgeon. He has a particular interest in refractive, multifocal and complex cataract surgery and minimally invasive glaucoma surgery. Dr. Rossiter Thornton is a lecturer at Sydney University and is actively involved in training and curriculum development for the College of Ophthalmologists. He holds public appointments at Concord and Campbelltown hospitals. So I'll pass over to you. Thank you, Michael.
Thanks very much. It's great to be part of this event. And I recognize I'm the last speaker of the evening, and I've got the scintillating topic of red eyes. Inevitably, this will be something of a shopping list, and I've done my best to systematize it, to give you something that I hope will be useful in terms of your assessment of patients. As we know, seeing patients with red eyes, painful eyes, uncomfortable eyes is incredibly common. And one of the biggest challenges is sorting those patients who can be managed safely in the community, those who need to be referred urgently, and those rare patients who actually need to go to hospital. So I've taken an anatomical or physiological approach to this. What are the things in the eyes or the processes in the eye that can be deranged in order to cause symptoms? And also the things to look out for so that you can recognize serious pathology. The main things are these symptoms accompanied by visual impairment? Are they chronic or recurrent? Is the patient experiencing double vision or proptosis, or has there been a recent procedure, specifically cataract surgery or an intravitreal injection? One of the key things here is that the history is often the most important thing in determining why the patient in front of you might have a red eye. Crucial questions: does the patient wear contact lenses? As mentioned, have they had a recent procedure? And other than that, are the symptoms in one eye or both? Have they experienced, to their recollection, any trauma or foreign bodies? Is there discharge? Do they know people who have similar symptoms at the moment? Is it accompanied by upper respiratory tract symptoms or other systemic symptoms? And have they had previous episodes or previous diagnoses, which may give you a clue to what's going on in this particular instance? I'm going to talk about conjunctivitis first. Very important to go through that. And Dr. Wells has already gone through allergic conjunctivitis and covered most of the main points. But patients will often present with this. It may come out of the blue, or they may have been suffering with it for some time. The discomfort may be experienced predominantly as itch. A watery discharge is usually present. It's managed with antihistamines and mast cell stabilizers, and in some cases, topical steroids. It's crucial that patients use topical lubricants just simply for their diluting effect on the ocular surface. And in some cases, patch or allergy testing can be useful to isolate the allergen that's responsible. Infectious conjunctivitis is probably even more common. It's important to recognize that in almost all cases, it's also very contagious, particularly viral conjunctivitis. Patients will be uncomfortable, they'll be experiencing a thicker, more mucousy discharge, and it will be associated with conjunctival and eyelid swelling. In some situations, as you may have experienced, it can be difficult to distinguish between an infectious viral conjunctivitis and a preseptal cellulitis. And if you've ever been in this situation, please don't be alarmed. It's something that we struggle with sometimes as well. And certainly patients with conjunctivitis have sometimes been admitted to hospital for intravenous antibiotics before the diagnosis has become clear. The most common cause of viral conjunctivitis is adenovirus. So patients often also experience OT symptoms. HSV, VZV can also do it. And surprisingly, conjunctivitis is also the most common ocular manifestation of COVID infection. Sorry, that's my cat who's just peeking up from below. He's tucked up on my lap. Now, this is what applies for acute conjunctivitis. Chronic conjunctivitis is different. And if a patient is experiencing chronic conjunctivitis, that must be a clue that something more serious or more sinister may be going on. In general, infectious conjunctivitis is treated with conservative measures, topical lubricants, lid hygiene, and hand hygiene is very important to avoid spreading it. It's rare that conjunctivitis can be associated with vision-threatening sequelae, but it can happen, and steroids are usually reserved for those situations. Chlorsig is commonly prescribed, but is actually very rarely required. Even in cases of bacterial conjunctivitis, most will resolve by themselves. And it should be borne in mind that the preservative load in conjunctivitis can add to the patient's discomfort. Now, neonatal conjunctivitis is a different story, and it is one of the true ophthalmic emergencies. The definition of neonatal conjunctivitis is any conjunctivitis occurring within the first month of life. The reason it's serious is because it can lead to corneal perforation, permanent visual loss, and if an infection is established that is serious enough, it can actually be life-threatening. So here are some images of what it looks like. The thing to remember is that if you see conjunctivitis within the first month of life, that is an emergency. Doesn't matter how serious or how mild it looks, it needs to be urgently assessed. Now, in some situations, it will be assessed and it'll turn out to be something not so sinister like a nasal duct obstruction, but err on the side of getting the child assessed very quickly. If it's ophthalmia neonatorum, the patient will be admitted to hospital and they'll be treated very aggressively. Corneal foreign bodies, incredibly common. Usually the history is the clue. It can be very difficult to see foreign bodies. This photo up here, you may be able to appreciate that there is a very small central white foreign body, but I think we would struggle to find this without a slit lamp. This one down here is a bit more obvious. This is a huge foreign body that's actually penetrated the cornea. That's extremely rare. Now, the question is, should you try to remove this yourself? We have it easy with our equipment. I would say if you're ever in any doubt about a foreign body, it's absolutely fine to refer it on to someone who is comfortable to remove it with all the equipment that we have. Corneal foreign bodies tend to recur because the situations in which patients sustain them tend to occur again and again. Grinding, metal work, industrial exposures, things like that. Prevention is very important. If you see a patient with a foreign body, it's often a good opportunity to say to them, please wear protective goggles next time. This is the bottom photo, what actually happened for this patient when he had to be removed from the eye. Had to go to theatre to have it removed, and as you can see, the cornea had to be sutured. I stress this is very rare, and most foreign bodies are not this serious. Epithelial defects, very, very common. Again, the history will be the key. The patient may recognize or remember the trauma that caused it. In some cases, patients can experience scratches to the cornea when they're asleep. They roll over at night, the pressure of their eye on the pillow, the eyelid will open and the cornea will be rubbed, and they can get defects such as this. The key thing is that it will be visible with fluorescein staining and a cobalt blue light, if you have access to that. If the defect is large enough, it will also be associated with corneal edema, which may be appreciated as a diffuse haze of the cornea. In some cases, a mild uveitis will be present, although this is not the predominant feature. It's treated with chloramphenicol ointment and drops, rest. In general, we avoid padding or patching the eye in case the presence of the patch may actually exacerbate the injury while the eye is uncomfortable and painful. Herpetic keratitis is a slightly different one, and you'll probably all be familiar with what this looks like, the classic dendrite. It's pathognomonic, but it doesn't have to be present in order for the diagnosis, or in order for it to be HSV keratitis. And the other things, as a bit of an aside, they don't have to, herpetic keratitis does not have to present with it. It doesn't have to have that shape. The other type of corneal defect that we see in herpetic keratitis is the geographic ulcer. And I saw this defect in this patient who had herpetic keratitis, and I said to my registrar, that certainly is geographic. It looks vaguely like the geography of Korea. And they didn't agree with me until a week later when they looked it up and they realized that indeed it does. So this is just one of the odd things that can happen with corneal defects. They can assume unusual shapes. Herpetic keratitis is treated with specific antivirals. And the difficult thing is that it tends to be recurrent. So patients may be aware they've had it in the past. When it does recur, it can be associated with significant ocular morbidity. The location of the dendrites can become scarred. The patients can develop glaucoma. And in very rare cases, there can be retinal involvement, which can be blinding. Now, contact lens-related microbial keratitis is one of the most severe things that can happen, as this picture demonstrates. This patient has a huge corneal abscess with a hypopion. The key thing to recognize this is to establish whether the patient in front of you with a red, painful eye wears contact lenses. And if that is the case, they need urgent referral and assessment. I'm just going to jump to the next photo. This is a patient I saw many years ago, contact lens wearer, who presented with her eye looking like this, the cornea already devastated by an established pseudomonal infection. And in cases like this, the scarring is so devastating that the only outcome once the infection is under control is corneal transplantation so that sight can be restored. There are things that can be done to lower the risk of contact lens related microbial keratitis, daily disposable contact lenses, and limiting the rate at which they're worn. So a couple of days a week with no contact lenses and only wearing them for a certain period during the day. Of course, there are other alternatives to contact lenses. Every contact lens wearer should have a pair of glasses on hand in case a situation arises in which they cannot wear their contact lenses. The other option is, of course, laser vision correction, which I'll come back to at the end of the talk. Angle closure. The patient with a red, painful eye, the risk that they may have an angle closure crisis is probably the most feared type of cause, but happily it's quite rare. Now, for pressure in the eye to cause pain, it usually has to have had an acute rise to in excess of 40 millimeters of mercury. If the increase in pressure is slower, then it may not become painful until the pressure is actually higher than this. In some cases, in situations of angle closure, it's actually apparent that patients have had preceding symptoms for some months or years that haven't been recognized. And the difficulty is often it can only be recognized in retrospect. Usually, if a patient presents with an angle closure crisis, it's not subtle. They will have be in extreme discomfort. The eye will be red, they'll have reduced vision. The pupil will be involved. It'll be fixed and classically described as vertically ovoid due to the ischemia that's present. Patients will also have headache due to the extremely high pressure, nausea and vomiting, and sometimes systemic symptoms due to the massive vagal outflow that's associated with this pain. This is urgent. The patient needs to see us promptly, and in many cases, they'll end up in hospital. Now, uveitis is one of the difficult things because uveitis can be difficult to distinguish from angle closure, simply because the pupil can be involved, and in some cases, the pressure can also be high. There are multiple causes. Inflammatory and infectious are the most important. Scleritis is another diagnosis which is different to uveitis, and that's characterized by extreme tenderness of the globe. All of the other entities that I've mentioned, the eye is often sore, the patient will be quite tender, but in scleritis, it's extremely tender. This is the kind of diagnosis and differentiation from other causes of red eye that will need an ophthalmic assessment. A few other causes of red eye quickly. Thyroid eye disease is a very common cause of red, painful eyes. Thyroid eye disease can present along a spectrum from very mild to extremely serious, as you can see in this photo here. And interestingly, can exist in patients who have normal, high or low thyroid function. Neuro-ophthalmic presentations of red eye are uncommon, but they're potentially serious. So be aware if the patient's symptoms are accompanied by proptosis or diplopia. And finally, because I didn't really have a good place to put it otherwise, subconjunctival hemorrhage, which is the other end of the spectrum, something that is usually completely innocuous, but surprisingly, one of the most florid and dramatic presentations that the patient may have. Often it occurs from innocuous trauma, and it can be associated with swelling of the conjunctiva, but often all we need to do is examine the patient and reassure them that it will settle down. So hopefully this has been a systemized approach to the red eye, the common things, the serious things, and the things you need to look out for. Please remember, does the patient wear contact lenses? Are there any pupil abnormalities? And has the patient had a recent procedure? The final thing I want to talk about in the last few minutes is laser refractive surgery. For many patients, it is an excellent option so that they can avoid wearing glasses or contact lenses. And having seen some of the things that can happen to patients who wear contact lenses, you can probably understand why it is an option that many patients entertain. It is safe, effective, and it's also very, very common. And for this reason, it's entered the popular consciousness. There are many lasers that we use in ophthalmology, retinal lasers, lasers for pressure. But when you mention laser to a patient, they assume that you're talking about LASIK. So when we are talking about these other types of lasers, we often need to differentiate them and say that this laser will reduce your pressure or will fix a retinal tear, but it will not reduce your need for glasses. But the key thing with this is selecting the right patients. Now, just briefly, how does laser refractive surgery work? To go back to the most basic optics, the eye is effectively a dual thin lens system. Light comes in, is refracted through the cornea, then to the lens, through the lens, and onto the fovea. Ametropia or refractive error exists when this light is not adequately focused onto the fovea, and can occur for the reasons mentioned there. The solutions are to alter the lens configuration with glasses, contact lenses, in cataract surgery or lens replacement by actually replacing the lens. But in this situation, what we're talking about is using laser to reshape the cornea. And what I've got here is a 20-second video showing the most simple and I think the most effective type of laser refractive surgery called trans-PRK. The patient has been given some sedation. This is the operating microscope. And you'll just appreciate that there is a very subtle centrifugal pattern spreading out on the cornea. That is the trans-PRK being delivered. And it's as simple as that. Now on to the next one. So as mentioned, that's trans-PRK, which is the simplest technique. It has the least tectonic effect on the cornea. The more popularly known types of laser include LASIK, which is a two-step procedure rather than the one-step trans-PRK. The difficulty with LASIK is that it involves significant transection of corneal nerves, so the patient is predisposed to dry eye. And due to the two-step, the creation of the flap, the patient always has a lifelong risk of developing ectasia, or a severe condition which can lead to corneal transplantation. A newer type of laser is called SMILE. Again, it's a two-step procedure, and at this stage, there hasn't really been enough experience with the procedure to establish its efficacy, as well as trans-PRK or LASIK. So basically, when a patient comes for assessment, it's a very detailed discussion. It involves establishing what they hope to achieve, and remembering that after the age of 40 to 50, no one who can see clearly in the distance will be free of reading glasses. Everyone will still get cataract. So there are limitations to the procedure, and everyone who's going through this needs to understand it. If you have a patient who you think might be appropriate, we'll be most happy to have a chat with them about it. Just remember that not everyone is suitable. There are limitations. But with that in mind, if you have anyone in mind, we'd be most happy to have a talk with them about it. And just in the interest of time, I might leave it at that.
Lovely. Thanks very much, Michael. That was perfect. Hit the spot. We've got a little bit of time for a couple of questions, so send them through if anyone has any final questions. I might just ask, with HSV keratitis, what sort of time frame do you think they need to be seen by an ophthalmologist? I mean, if we see them and start them on antivirals, do you think they need to see you the same day? Is it okay if we get them in with you in the next sort of 24, 48 hours?
I think that time frame is quite reasonable. Earlier the better, of course. But just with the vagaries of how these things happen, 24 to 48 hours is usually very reasonable. The most feared complication with an acute presentation of HSV keratitis is a deeper involvement of the eye, or even involvement of the retina, which I stress is extremely rare, but that is the thing that even in young patients can be a devastating and life-changing diagnosis. So prompt referral is always better, but I think 24 to 48 hours is usually reasonable.
And similarly, time frame, I guess, for a foreign, like, fairly superficial foreign body that we don't feel confident to have a go at ourselves, do you think same day need to be seen, or if we patch the eye and get them to see you in the next, again, 24 hours?
In my experience, the limiting factor there is often the patient and when they can come in. And conversely, often they will want to get it addressed as soon as possible. So yeah, again, as soon as practical.
Lovely. I'm just going to have a quick look and see if there's any final questions coming through. Doesn't look like it. There's no final questions. I would like to thank all our speakers tonight from Sutherland Eye Surgeons, Associate Professor Matthew Sminovic, Dr. Michael Davies, Dr. Matthew Wells, and Dr. Michael Rossiter Thornton. Thank you very much for your time, and thank you all for your attendance.